immediately born or present. There's something wrong with this. It's not working right. I'm not getting any picture or any sound.
Just a minute. I think it's because it hadn't started yet.
Hi, everybody. Welcome to this presentation for our MAP series of lectures and discussions, medication management and movement disorders. Now, this is an update. So we're going to go as far as 2022 when it comes to understanding the new and the older medications that we have in our armamentarium of combination medications that we utilize to combat Parkinson's disease. I am Yasar Torres-Yaghi. I'm calling in from Georgetown University. I'm the director of the Parkinsonism and Dementia Clinic and assistant professor of neurology and movement disorders. I teach medical students, residents, fellows, and I love these sorts of presentations because they help me continue to educate and empower our community, our patients, give hope, stay positive and optimistic. Our medications give us that sort of forward momentum when it comes to all of the therapeutics that we have now to combat Parkinson's disease in 2022. But let's move on to amantadine. Now, amantadine is an antiviral. Initially was an antiviral medication. It was found to be helpful in Parkinson's disease. We use it for tremor, slowness of movement, rigidity, dyskinesias. The exact mechanism is unknown, but what we know is that it's probably a multifaceted mechanism. In part, it blocks a receptor called NMDA. And because it does that, in addition to some of the other things like enhancing release of stored dopamine, so it kind of enhances release of dopamine, but it also blocks NMDA receptors. It may actually be helpful for utilization throughout the spectrum of Parkinson's disease. But we'll learn now that there is a long-acting formulation that became available recently or in the recent past, which can be used to not just improve wearing off, but also improve levodopa-induced dyskinesias. The side effects, of course, we have to think about are things like changes or alteration in blood pressure, low blood pressure, swelling of the leg, confusion, and other psychiatric things. But in the immediate release formulation, as we used to use, the 200 to 300 milligram doses per day is really what we're looking for, so that we don't get into that risk profile of adverse effects. Now, I talked a little bit about where we were headed, and this is the actual data from a paper that was published in 2017 that looked at a reformulation of amantadine, a long-acting formulation, amantadine extended release. And it was utilized in patients that were experiencing both dyskinesia and wearing off. And what we saw in these patients was that there was actually an improvement in this pivotal study. There was an improvement of levodopa-induced dyskinesia, and there was an improvement of wearing off time as well. And so this medication is, in fact, one medication that has two indications. It's for reducing levodopa-induced dyskinesias, and it also has an indication for improving or targeting patients that are having wearing off. Based on the data, we can see an improvement of both things when utilizing amantadine extended release. Now, let's dive right into carbidopa levodopa, understand it. You know, there's different ways to call it, but carbidopa levodopa is usually the gold standard of treatment. It's also the gold standard way of saying it, although we may know it also as Sinemet, which means without emesis. But what we see here is that since the 1960s, it has become the drug of choice for Parkinson's disease. We know it's a large neutral amino acid, and that helps with blood-brain barrier penetrance. And when combining levodopa with carbidopa, the idea is that carbidopa may help block the breakdown of levodopa within the blood once it crosses from the GI tract to the blood, so that you don't have as much breakdown, and maybe, hopefully, you have less nausea. Although nausea, of course, is part of the side effect profile of carbidopa levodopa. Postural hypotension, dyskinesias, and things like that are things that we look for and we counsel our patients about. Now, there's different types of carbidopa levodopa. There's immediate release and different doses. We know that the onset should be anywhere between really 20 to 40 minutes or close to 60 minutes. The duration of benefit based on the half-life could be about 2 to 4 hours. There's an oral disintegrating form of carbidopa levodopa immediate release. There's a controlled release form of carbidopa levodopa that may have an onset of action of starting to take effect at 30 to 60 minutes and maybe last a little longer than the immediate release formulation. And then, of course, there is a relatively newer medication called inhaled levodopa. It's levodopa, but it's inhaled. And the idea is that it bypasses the GI tract so that it can act more effectively and more rapidly. So the onset could be anywhere between 10 to 30 minutes, and the duration of benefit could be up to 1 hour, but you utilize it as a form of as-needed medication. We're going to understand that a little bit further as well. But now that we're on the topic of carbidopa levodopa, it would be important to also understand that there is an extended release formulation. Now, this is a paper that was published back in 2013 that really delineates the different outcomes when it comes to the benefit of utilizing an extended release medication. Here you see that in the 201 patients that were part of this clinical trial, the patients that had wearing off, and the time that they experienced wearing off was similar in both groups. And what you see is that there were patients that had their immediate release carbidopa levodopa optimized as much as they could. So in order to combat the wearing off, they said, okay, well, maybe we'll take your carbidopa levodopa more frequently, or maybe we'll do a higher dose per dose administration, that sort of thing. And those patients were compared to other patients that were in the group where they switched to this extended release formulation of carbidopa levodopa. So the extended release formulation of carbidopa levodopa, in fact, in that group, patients were taking the medication on average 3.6 times per day. So anywhere between 3 to 4 times per day. And they had a reduction in their off time and an improvement of their troublesome dyskinesia. So overall, patients were taking their medicine between 3 to 4 times a day in comparison to the immediate release carbidopa levodopa group that had more wearing off and more troublesome dyskinesia. And those patients were on average taking their medicine 5 times a day. So that kind of helps us understand that if you utilize a new formulation like this extended release carbidopa levodopa, you may in fact reduce that daily off time by a delta of about 1.17 hours if you compare to optimizing your immediate release carbidopa levodopa. And so what that means is also that you might be taking your medicine less frequently. We all know in Parkinson's disease that we might take our medicine very regularly. We call that the pill burden. The pill burden is high. The amount of times that we take a carbidopa levodopa can be multiple times a day. Can be with a dose frequency sometimes of every 3 hours, multiple times a day, sometimes 5, 6, even more times per day in certain cases. And so utilizing these extended release formulations can be helpful. Now, what's another type of levodopa? Well, there's carbidopa levodopa, but an enteral suspension, which means that it can go through an intestinal gel formulation that's utilized through a cassette and goes in through a medication infusion port through a tube that goes inside the stomach and then into the small intestine where Carbidopa Levodopa gets more readily absorbed. Now, this is a paper that was published in 2014, and in big centers and in places where they have good subspecialty care for Parkinson's disease, and in general, all of our Parkinson's doctors, healthcare practitioners, our physician assistants, and nurse practitioners would know that utilizing medication that can help smooth out the way the medicine goes up and down in your body can be helpful. And what we see here is that Carbidopa Levodopa intestinal gel administered through a medication infusion port. If you compare patients that were not on the pump to patients that were on the pump, what you see, in fact, was that there was a mean reduction, a change from baseline at 12 weeks of about 4 hours in comparison to an improvement of 2 hours in the oral group. So what we see here is that that was about a delta of about 2 hours. And then the on time without troublesome dyskinesia also improved by about 4 hours in comparison to 2 hours. So what we see here is, you remember, it's one coin, but there's two sides to the coin. There are dyskinesias, which we want to smooth out and lessen as much as possible so that they're not as troublesome. And then we want to improve off time so that there's less troughs. And so what we saw here with this constant kind of persistent amount of dopamine, carbidopa, levodopa infusion on a continuous basis, we're able to smooth out those peaks and fill in those troughs and hopefully stay within that therapeutic window. Now let's switch gears and start talking about our monoamine oxidase inhibitors. We go back to Resagiline, which is an irreversible monoamine oxidase B inhibitor. We know that in the past, it's a medication that was utilized at 5 milligrams twice a day, hopefully as a gold dose. And the idea is that it augments by blocking an enzyme that breaks down our dopamine, allows for more dopamine to be in our system, our own endogenous dopamine. And so the things we think about in terms of side effects are insomnia, hallucinations, nausea, orthostatic hypotension. But there are other drugs within this drug category. Resagiline is one that can be used as monotherapy or as an adjunctive agent to some of your other medications, including carbidopa levodopa. And we utilize it with hopefully a gold dose of 0.5 milligrams to 1 milligram every day. And based on the clinical trials, it may increase the on time by up to 2 hours in a day. And you might utilize it with levodopa. And there were different studies that looked at the benefit of motor benefit that it gave, but also there was a study that looked at cognitive benefit, perhaps, with the utility of Resagiline. So it may help across the board with our Parkinson's symptoms. This is one of what we call the pivotal studies. The pivotal studies are important trials that we study when we become movement disorder specialists in those 34 years, including preschool, to become one. And what we see here is that in the patients that took Resagiline, those patients were actually having off time. They were having those motor fluctuations. And they had at least 2.5 hours of off time. And what they saw in the clinical trial was that there was an improvement. There was an improvement of off time. And comparatively, what we saw here was that during the treatment period, the mean adjusted total daily off time decreased by about 1.85 hours in the patients that were treated with the 1 milligram dose of Resagiline. And you can see that over time in that graphic, that the long dotted line are patients that were on placebo. Their mean total daily off time improved, but not as much as those that were on the 1 milligram dose of Resagiline. The Ceramide is a monoamine oxidase B inhibitor. It's a reversible monoamine oxidase B inhibitor. And interestingly, based on the clinical trials, what we think it does, it has kind of an action where it blocks monoamine oxidase, so it helps with that dopaminergic action within those neurons, but it also may ultimately inhibit the abnormal release of glutamate, which means that it might actually control some hyperexcitability in the brain, which may lead to dyskinesias. And so what we think when you utilize a medicine like this is that once you get up to the gold dose of 50 milligrams to 100 milligrams, that based on the clinical research, that not only might it help improve or reduce off time, but it might also help reduce the troublesome dyskinesias that might occur. So we have a newer formulation of a COMT inhibitor called opicapone, and this is data from a 2016 paper. And what I'm showing you here essentially is that if you look at the reduction in absolute off time, patients that were on 25 milligrams or 50 milligrams of opicapone, which is a once-a-day COMT inhibitor, in fact did see in a 14 to 15 week double-blind period, what they saw was there was a reduction in off time, about 101 minutes in the 25 milligram group and close to 120 minutes in the 50 milligram group. And so those are the things that we look for whenever we're analyzing data, is seeing about off time and off time improvement and things like that. What about A2A antagonists? Now, in 2019, we were able to kind of understand the utility more based on Japanese clinical trials. This was a medication that was approved in Japan prior to the United States, and 2 pivotal trials in the United States. And we looked at the data, and what we learned from a lot of that work was that A2A receptors are receptors that we might see that are upregulated in Parkinson's patients. So as Parkinson's progresses, you might get this increase in these receptors sitting in the basal ganglia circuitry. Now, there are 2 pathways in the brain that modulate movement, that kind of titrate our movement. And there's one pathway from the brain through the basal ganglia that is called the direct pathway. That's our go pathway. That's our gas pedal. And there's an indirect pathway that goes through different parts of the brain that is our brake pedal. And we use those 2 circuits in combination, similar to driving a go-kart. You have the gas pedal, the brake pedal. In order to move, we need to hit the gas and take our foot off the brake. What we know is that indirect pathway, which is our brake, has a lot of A2A receptors in Parkinson's. So we use medications like an A2A receptor antagonist called istradefylline as an adjunctive medication to carbidopa levodopa to hopefully take that foot off the brake so that our Parkinson's patients can move better. And that's kind of the idea behind why we might utilize these medications. And we learned through the clinical trials why that might be a good strategy. So when it comes to as-needed medications, what we see here is that there are different options. We have the injectable apomorphine on the left. We have sublingual apomorphine in the middle, and we have inhaled levodopa on the right. And so on the left, what you see is the injectable apomorphine. Based on the clinical trials in general, what we see is that it works at about 20 minutes after it's given based on the clinical trial. And we might see a reduction in our UPDRS motor score, which is our severity scale, by about 23 points. The sublingual apomorphine, which goes under the tongue and helps work that way, we see at 30 minutes after a dose, we see an improvement in motor symptoms. And then if you look at the inhaled levodopa at 30 minutes post-dose, what we saw was an improvement in motor symptoms as well. And so there are all these different strategies that we can utilize in an as-needed fashion that really changes our treatment paradigm, because now we use adjunctive agents, extended release formulations of medicines, extended release formulations of carbidopa levodopa in combination to combat wearing off. But if we still have wearing off in between our carbidopa levodopa, we have an action plan. That's what I tell patients. We have an action plan in case we have wearing off. Now remember, wearing off can happen in all shapes and sizes. It can happen in the morning, even as we're waiting for our carbidopa levodopa to kick in, that time where it takes our carbidopa levodopa to kick in, also we're not feeling as good as we could. That's called morning akinesia, or morning off. You can have wearing off throughout the day. If you're constipated, you might wear off more. If you're eating protein while you're taking your carbidopa levodopa, and some, you can see a reduced benefit. You can have what's called a missed dose effect, where you take your carbidopa levodopa and it's like you never took it. You can also wear off in the middle of the night, right? How many times do we wake up with sleep fragmentation in Parkinson's disease? We're going to talk about sleep in another lecture, but the sleep fragmentation is something also that we think about. That could be a wearing off episode. If it's hard to turn in bed, if you get nighttime cramping. It's been a long time since your previous dose of carbidopa levodopa, or even a short time, that still could be wearing off. And so we can utilize these on-demand or as-needed therapies to help with that. Now, there's different therapeutic approaches. This is almost a beautiful summary slide of what we had and maybe where we're going and where we are in clinical research and newer modalities. Now let's just look at what we call the on extenders. Those are the adjunctive medicines, many of which we've talked about prior to this slide. What you see here are COMT inhibitors. Remember, we talked about entacapone and opicapone that might reduce off time. Monoamine oxidase B inhibitors. Remember, we talked about Selegiline, Resagiline, Ceramide. Dopamine agonists. We talked about ropinirole. The rotigotine patch, which is changed every 24 hours. We talked about pramipexole, which also has an extended release formulation. We talked about levodopa infusions with the Carbidopa Levodopa intestinal gel, which goes through a medication infusion port that you turn on the pump, and it helps stabilize things over time. You turn it on in the morning, you turn it off at night, and that would replace mostly your oral Carbidopa Levodopa throughout the day with a pump that infuses Carbidopa Levodopa through a medication infusion port. Now, what about the as-needed on-demand therapies? We talked about them, the levodopa inhaler, the apomorphine sublingual under the tongue, subcutaneous apomorphine pen injection. Those are utilized as needed therapies. As you see, we're utilizing all these meds in combination, right? We might have the on-extenders, which are help for maintenance, and then we have these as-needed therapies. Now let's move over to the top right and look at devices. You see, that's what the LCIG device looks like. The pump that I talked about, that pumps Carbidopa Levodopa intestinal gel through a medication infusion port into the GI system. Now, if you look to the side, there is something in clinical trials that's looking at a pump of Carbidopa Levodopa, again in clinical trials, that can be pumped into the skin with a patch pump. And so that's something that we're studying now to see if that could be effective and safe. And then we have, of course, subcutaneous apomorphine infusion, actually in Europe, but is in clinical trials and at a stage where publications have been reviewed for a subcutaneous apomorphine infusion. So the dopamine agonist medication that pumps through a patch pump into the skin, so subcutaneous. Now let's look down and let's look down to surgical treatment modalities. Now, deep brain stimulation, of course, we know very well, and so that's basically an electrode that's implanted in the brain. Different parts of the brain could be implanted at the subthalamic nucleus or the globus pallidus, depending on your clinical symptoms. Those are the things that we talk about as movement disorders doctors and patients to come up with what location would be best for each person. Remember, everything is individualized. We have to take every case and try and think about all the comorbidities, all the different non-motor symptoms, and kind of combine them together to come up with an effective treatment strategy. But the good news is we have a multitude of treatment strategies. Look at this. We have on-extenders, we have as-needed medications, we have device therapies, we have surgical treatment modalities. And this is why in 2022, we have hope, we have positivity, and that's really, our optimism really has to do with our therapeutic landscape and all the things we can do to help. That energy, that positive energy is there, and that positive energy is there with clinical research. We have so much going on, and so that's what I tell our patients, and I want everyone listening on the other end of this presentation to also feel that. You see on the right, actually, what you see on the right is an MRI-focused ultrasound. That also is in the process of being understood by the clinical community, but also it's in clinical practice, MRI-focused ultrasound to improve tremors. But again, that's something that we need to continue to kind of dive into deeper and understand the clinical data as well. Now, what is this? This is what I'm showing you in Parkinson's disease in comparison to a patient that may not be affected with Parkinson's disease. What we see is that there's less acetylcholine in the brain. Patients that have cognitive impairment due to Alzheimer's have lower acetylcholine, but not as much as Parkinson's patients. We see a greater acetylcholine reduction in Parkinson's patients, which means we're going to switch gears and talk about our cognitive medicines to understand them a little bit more. Because let's not forget, cognition is very, very important when it comes to Parkinson's disease. And oftentimes it can be missed or not discussed. And so it's an important thing to discuss. And the reason I bring this up is because if you look at acetylcholine as a chemical, we talked a lot about dopamine, right? But if you look at acetylcholine as a chemical, acetylcholine is important for your cognitive capability. And because in Parkinson's disease with cognitive impairment, we see lower levels. We can utilize medicines that work to help augment acetylcholine, and patients can be very responsive to those medicines. The medications that we use in particular, based on the guidelines, the movement disorders guidelines, the most recent published movement disorders guidelines. We use rivastigmine. It's clinically useful. It can be taken as an oral pill or as a transdermal patch. And what that does is it augments acetylcholine levels. Donepezil is also a medication which is called an acetylcholinesterase inhibitor, you see on top there, which could be possibly useful. We use it. It can increase acetylcholine levels. And then we also use medicines like memantine, memantine is within a category of medicines called the NMDA antagonists. And it's something that can be used for cognitive impairment in combination with either rivastigmine or donepezil. The other thing that's been studied, and research may suggest some previous trials looking at Parkinson's disease with mild cognitive impairment. Resagiline, may be helpful for that, but again, based on guidelines, you have to go with the data, of course. The other thing that we do, is not medication, it's non-pharmacologic intervention. We do things like cognitive rehabilitation, things like improving nutrition, improving sleep quality, exercise, hydration. All of those things can be helpful. You can see a speech therapist or a neuropsychologist that goes through brain training exercise. That can be an order and a referral for cognitive improvement without having to utilize medications. Now, what about psychosis? Psychosis, what that means is if you have what's called hallucinations or fixed ideas. Hallucinations can be you either see people or feel people in the room that may not be there, animals or other figures. And those are things that we think about in Parkinson's disease that can be very, very helpful in understanding, because there are medications that we can utilize. The medications we think about, of course, and based on clinical research, it could be pimavanserin, which is efficacious and it's acceptable based on the guidelines of risk without necessarily having specialized monitoring. It can be clinically useful based on clinical trials. It's FDA approved for Parkinson's disease psychosis. And that in contrast to clozapine, which can be used, it can be clinically useful, but you need specialized monitoring. You actually need weekly blood draws for that because of the risk, the side effect risk of blood count changes that can occur. Quetiapine is also used, it can be possibly useful, but the idea here is that we utilize medicines to help combat psychosis if we do experience it. So not only do we have medicines for cognition, but we also have medicines for psychosis. Now, I know this is a rapid review of all the medicines, and all the different treatment options really. What we see here is deep brain stimulation. We know what it does is it's an electrical pulsatile electrical field. And we target the nuclei in the brain, as we mentioned. It can be turned on and off. The exact physiology is not fully known, but we know what it does is it can create this electrical field that may actually mimic almost like an ablation. So it kind of creates that sort of electrical field, but what it does is it helps reduce Parkinson's symptoms. Based on the pivotal studies and many clinical trials, we learned that, for example, if you place an electrode in the subthalamic nucleus, what we could see based on clinical research is an improvement in our motor function scale by about 60%. On time improved as well, where our patients felt better. Off time improved, and we reduced dyskinesias that were troublesome. And we also, in fact, reduced medication requirements. You can actually lower the amount of Carbidopa Levodopa that you're taking after you get deep brain stimulation. And so in conclusion, just to kind of go through this quickly, we have multiple medications to help improve our quality of life. Each patient is individualized. Each patient's clinical symptoms are all personalized to their own case. Remember, if you've seen one patient with Parkinson's, you've only seen one patient. So everyone has different symptoms. You always have to screen for, understand them, listen, communicate. That's the key to a successful outcome, communication. Understanding how to communicate for patients and understanding how to listen, what to ask for as clinicians and movement disorders subspecialties. Polypharmacy is common. We don't use irrational polypharmacy. We use rational polypharmacy. We create these combination of medicines to create stability. So we always try to utilize medicine. What might work for one patient may not work for another, and vice versa. And so we're always utilizing this team effort approach, making sure that we're trying to optimize therapy, improve quality of life, educate, communicate. Hopefully a lot of what I said, it kind of shines through as positive and impactful in a way where we have hope with these therapeutics. Now, if we want to understand DBS a little bit more, just quickly before we end, remember that DBS is reversible. It doesn't destroy normal brain tissue. It can be adjustable, it's bilateral. And these are just different DBS devices. On the left, you see there is a device that, in fact, with the new software upgrade, with the new impulse generator, which is the battery that's placed, that's in the chest wall, that's connected to the electrodes in the brain, can actually sense brain waves. And we can perhaps try to understand that a little bit further based on the motor changes that happen in our patients. In the middle, we see actually remote programming. There's a device there's a DBS system that you can actually do remote programming. So you can be the doctor or healthcare practitioner can be in the office, and you may be at home and you can adjust the deep brain stimulator. On the right here, you see another system that's very helpful with the user interface that allows for programming throughout all of the contact points on the electrode. And in fact, this system has 8 contact points, which can be helpful. So you can utilize, rather than 4 contact points, in some patients, 8 contact points. So you have more places where you can stimulate with an electrical field. So this, if we think about all of the wonderful things in Parkinson's disease, not only did we run through quickly in one lecture, of course, we could probably speak a whole day on all of these things, but in one lecture, we talked about oral therapeutics, the older medications, the newer medications. Remember, reformulations of medications that help extend the duration of benefit can be helpful as Parkinson's disease therapeutics continue to advance. We talked about devices that we have to prescribe right now and in clinical research, and things that we're learning more about, things that have recently come out in terms of surgical treatment modalities, and then DBS, in addition to some of the cognitive medications and neuropsychiatric medicine. So I appreciate so much you all listening. Thank you for tuning in during a virtual presentation. Again, my name is Yasar Torres-Yaghi, and I hope this was a positive experience and that everyone leaves this or turns off this presentation feeling hopeful, positive, happy that we have so many different options to help with our Parkinson's patients. And so hopefully I imparted that to all of you. I appreciate you listening. Thank you so, so much, and have a wonderful, wonderful rest of the day.
Do we have any questions?
Hi, how are you?
Oh, hi, everybody.
Hi, Yasar.
Oh, wow.
We're all here.
Good to see you
Good to see
virtually
you.
on video.
Good work and good talk.
Good. Was it nice? Was it positive? Did people,
Yes.
people felt good and hopeful at the end of it?
Yes.
Good. Because we
All
talk
right,
a
so
lot
we-
about so
Dr.
many things.
We have our
Dr.
first.
Yaghi?
Yes.
Oh no, it's not a question, it's a statement. This is Lenora Murky. I work with Mike Sampson and I never had a chance to meet you, but my son and I are driving out to a soccer game right now and I go, we're listening to this. My son is 12 and I'm like, he's learning everything, but he's like, he's so happy-go-lucky. He's such a nice guy. So when you're saying hope,
Oh, I think we lost her.
That's so nice.
That was like totally hopeful, and you kept your enthusiasm wonderful.
Oh, thank you
We
very
have some
much.
questions now.
Hi, so I'm Jessica with MAPS and we have our first question for you. Can you hear me okay? What role will stem cells play?
Good question. You know, there's so many different types of clinical trials and experimental therapies that are ongoing right now. And what we know about Parkinson's disease is that the protein that develops in the body and in the brain and the nervous system, it develops in the part of the brain and accumulates, the alpha-synuclein accumulates in the part of the brain that's the dopamine center, the substantia nigra. And what we know is that that protein can kind of spread from neuron to neuron. So there's a hypothesis about how that occurs. Stem cells right now, what we've learned about, if you essentially use embryonic stem cells and implant them, and there's different ways of implanting them to kind of create these neurons, implantable neurons that may not be affected by the alpha-synuclein. Right now, what we've learned so far in clinical research is that, unfortunately, the stem cells also get affected with the same protein that we have, even though they've been implanted. So we're learning more and more about stem cells, and I think the more we learn through clinical research, the better we'll be down the road, because there may be a utility to them. But right now, we're still learning. It's experimental. We have to find a way that we can utilize stem cell therapy so that they themselves do not get overwhelmed with the alpha-synuclein protein that affects the neurons in our Parkinson's patients. So there is a role potentially in clinical research so far, but there isn't anything in terms of results that have allowed for stem cells to be utilized in clinical practice. But we need more to come. You know, we have to continue to learn with clinical research, and that's part of the momentum behind clinical research in Parkinson's disease. There's so much ongoing. Even during the pandemic, there's been so much ongoing, and now even more so. So hopefully there's more to come when it comes to stem cell therapy.
Great, thank you so much. This next question is, my Resagiline prescription states, take 1 tablet with breakfast and lunch. I sometimes eat at off hours. So is it more important to be on a one time or a meal regimen?
Great question. And this is tough when it comes to many of our medications, in particular with Carbidopa Levodopa. So Carbidopa Levodopa is the most important when it comes to that, because our levodopa, it competes with protein. So it's almost, the more protein you have, the less effectively you're going to absorb the levodopa. And so what I usually tell people is, it's important to stay on time, right? And so it doesn't mean you starve yourself. Remember, there's different kinds of meals. There's protein-filled meals, and then there's not protein-filled meals, right? In general, for our energy and for our brain and body, we do want protein, right? Protein is good for us. It makes us strong. It keeps us energetic. It's one of the best types of nutritious components that we can have. But if you have to take your medicine around the time where you're also eating, the one thing I tell patients is try to learn about what nutrition, what sorts of foods have protein and what sorts of food have low protein or no protein. If you're going to eat close to when you take your medicine, because timing is very important for your medicine, make sure, I don't want you to starve yourself, but what I do want you to do is eat something that's either low in protein or not very high in protein, meaning, or no protein at all. You can find something like a salad or something to hold you over, but that can get tricky and that can get difficult when you're thinking about multiple times a day dosing, when you're taking your Carbidopa Levodopa, sometimes 6-7 times a day. It depends on the person. And so what I tell patients is take your medicine on time as best as you can, but learn about the different foods so that you know, if I have to eat, of course, if I'm hungry, I can still eat, but I just need to make sure that it's either low in protein or no protein. That's kind of the rule of thumb. And it also doesn't happen to everybody. And so it's important to know if you are a person that does notice that if you're eating protein-filled meals or proteinaceous meals around the time that you're taking your medicine, if you do notice a less effective administration of those doses, then you might be prone to that, but not everyone is. And so it's important to learn yourself and your body as well. You're welcome.
Okay, great. The next question is focused ultrasound. Is that being used in the US right now?
Okay, yeah, so we're learning more about focused ultrasound. It is being utilized for tremor. And so we're learning more about its effect on tremor based on several studies, Israeli studies prior to its launch in the United States. What we know a lot about lesioning. Lesioning is a type of surgical treatment modality that creates a scar in the brain. And so when you utilize lesioning, what you're doing is you're kind of finding a part of the brain that we know is an important part of the brain to ablate. There's different ways of doing that. In the past, there was a very famous neurosurgeon that we learn about as movement disorder specialist, Dr. Cooper, who utilized either cauterization, which means heating up of the area, or freezing of the parts of the brain. And it can be also utilized, you can do lesioning also with radiation or with MRI focused ultrasound. So right now, lesioning via MRI focused ultrasound has been shown in clinical research to reduce tremor. But if you think about its effect on the brain, remember that it is damaging the tissue of the brain. And so we have to always think about the clinical research trials, but then how we think about utilizing these therapies in clinical practice as well. So there's of course utility to it. And so we have to learn more about its utility in clinical practice. But there are certain centers in the area that are utilizing MRI focused ultrasound for reduction of tremor. And so more to come on that as well. Great question.
Great, thank you so much. This concludes our breakout session. Please return to the meyerberg.org/LWP page. We have posted a link